Done? Okay, so good evening everyone. I hope that I am live now. Audio and video are fine. Please confirm once it is okay. Video is on, no audio, no audio. Just have a look again. Audio glitched. Is it so? Now please check it. Echo is there. Is there some echo? Please check. Echo. Asking the team to check it. Fine. So from our end it is fine. Please do just confirm at your end as well, the audio and video. Okay, so guys, yeah, it's fine now. Thank you. So first of all, guys, I welcome you all to this, the beginning of the new session of the Fast Track T&D. Okay, and yeah, and I do believe that it is going to serve the purpose that you are looking for, the complete recap of the subject as a whole. Okay, so today we are going to discuss the questionnaires of orthopedics, the MCQs, which will be covering all your content, whether it is from deformities, from trauma, from tumors, from infections, metabolic disorders, and everything else as well. Okay, so I am Dr. Sushil, your orthopedic faculty at DBMCI, and I am pretty much sure that this session is going to help you out and will definitely complete all your expectations, what you have been actually looking for. Okay, so guys, this paper, the T&D, has been purposefully kept like randomly, random questions. I have not kept it because this is a fast track T&D and you are supposed to read the whole content, but without a feeling that you already know the answer, that this is going to be coming from metabolic disorders only, or this is going to come from tumors only. So I have kept these questions at random so that when you're doing a question of trauma, the next question should be from tumors and from infection, so that our mind can run away. Okay, and just keep on thinking how to approach to a particular question. Okay, so I think no audio, not in synchronization now. Some of you are telling me that it is fine, some are telling not fine, but at our end I can see a camera in front of me. A screen is there which is showing me a proper relay, I guess. Okay, so just please confirm at your end as well. Right, so we'll be just starting with the questionnaire. The very first question that you see on the screen is a 12-year-old child. I think we are ready to start, everyone. Yeah, so my team member, kindly refresh it and it will be fine. Okay, great. So the first question that we have here is telling you that a 12-year-old child sustained an injury at the lower arm region. So we are talking about a topic from trauma. Okay, so injury at the lower arm region, age of the child is 12. It was managed conservatively by plaster application. So some trauma around elbow, around lower arm, which has been managed conservatively. Few months later, he developed swelling around the forearm region, and also noticed that he is unable to make a proper hold of any object with his hand. Now he is having this deformity of the medial two fingers, which is gradually progressive. What was the most likely fracture? So guys, what did you mark? We can have a quick, or whenever you answer, please make sure that whenever you are answering, make sure to answer as one, then your answer. Okay, otherwise what will happen? The answers will get jumbled as you are answering without question number. So put the question number and just put the answer. Very, very quick, we'll be just discussing that. Okay, so the very first question, old injury, managed conservatively. Now the child has got this problem where this medial two fingers are having a deformity, or the claw. So what do you think it is? The claw, you know that this area is a supply of which nerve? This area is a supply of ulnar nerve. And this ulnar nerve, as per the question, it is not getting involved immediately. It is getting involved after some time, right? So he is now not able to make the proper movement of the fingers few months later. Okay, so what we are talking about is a late involvement of the ulnar nerve. And where do we see the late involvement? What do you call that? So the situation here we are talking about is a tardy, the late involvement of the ulnar nerve. And where do you see the tardy ulnar nerve, Pelsi? It is seen with the fracture lateral condyle of the humerus, which had what complication? Fracture lateral condyle of the humerus, which has gone into what complication? The complication of non-union. So we all know that the fracture lateral condyle is also known as what? The fracture of necessity, isn't it? That is the fracture of necessity. Okay, that will be fracture of necessity. What all are the other fractures of necessities? All other fractures of necessities, one is a fracture neck of femur and other one is the fracture Gallisi. So please remember please remember, these three are the fractures of necessities all the time. And other than them, what all are the other fractures of necessities? The all other fractures of necessities, they can be like the intra-articular displaced injuries all the time. They have to be like fracture of necessities. Two-part fracture of olecranon, two-part fracture of patella. All the time they are supposed to be fractures of necessities. Okay, so these, if it not fixed, they will land up into a complication of non-union, and this non-union leads to what deformity? If there is a non-union over here, it will lead to a deformity like that, valgus. So that non-union leads to a progressive, this non-union leads to a progressive cubitus valgus. So the forearm going laterally. And when the forearm goes actually laterally, what will happen? All the structures here will be stretched, and that is what you call as the tardy ulnar nerve palsy. Okay, so every line, yes, absolutely right. Rakshita has answered it very, very correctly. So it's a tardy ulnar nerve palsy, the lateral condyle of the humerus getting involved. Okay, that was your question number 1. So answer is D. So second question, let's see that as well. 40-year-old man has sustained a minimally displaced fracture around the elbow. So now we have an elderly person who got a minimally displaced fracture around the elbow, and he has got extensive bruising and swelling of the upper forearm. So swelling, and this all the problem are here only, forearm area, but no open wound is there, so it's a closed injury. He has loss of sensation over the lateral aspect of the dorsum of hand. So he's got loss of sensation where? On the lateral aspect of the dorsum of hand. Lateral aspect of dorsum of hand, this area. So what this area will correspond to which nerve? Which is the most likely structure involved? Can you all say? Which is the most likely structure involved here, guys? So here you are talking about the hand, the dorsal aspect, and this area, you know, is supplied by superficial branch of the radial nerve, right? And that is basically the branch of the radial nerve itself. When the radial nerve is getting bifurcated into branches, one which is remaining superficial here in the forearm area over this area, right, which is supplying the dorsum of the hand area, and one which is going through the radial head into the behind the interosseous membrane. That's what you call the posterior interosseous nerve. That's what you call the posterior interosseous nerve. So this answer here should be ideally the radial nerve itself. I'm sure you are clear with this. Now these two questions, guys, these two questions are checking what? These two questions are telling you or asking you the questions where a particular area, the particular bone, the fracture has happened, and now after that fracture, some nervous involvement, some nerve is involved, and that nerve involvement is causing some sort of presentation in the patient. Now if you realize the difference between the previous few years of the questions and the new question, the difference has been what? Nobody nowadays is interested in asking from you that which is the fracture, what is the site of this fracture. No, they give you some presentation of the patient, the clinically oriented, presentation of patient, and they ask you that why the patient is having this kind of presentation. For example, shaft of humerus, you all know it involves most commonly which nerve? The radial nerve. But now in the last year Neet exam 2021, what was the question? Question was, a patient has got a fracture, comminuted fracture of the shaft of the humerus, and after comminution, now the patient is not able to flex his elbow, and there is loss of sensation on upper lateral aspect of the forearm area as well. You got this point? So patient is having the same injury, fracture shaft, but they want to know the nerve involved if the patient is having some other presentation. So most commonest nerve involved here is radial, but in this question, flexion of elbow is a problem. So which is the nerve involved? That is your musculocutaneous nerve. We all know that. That will be a musculocutaneous nerve, right? Isn't it? So that's musculocutaneous. So what I was just talking about is, nowadays the clinically oriented thing is the problem with the movement in the patient's limb. So problem in the movements can happen because of two reasons. Either it is some trauma which involves the nerve itself, or some trauma which involves the muscle itself. So it can be nerve or it can be muscle, right? So now I would like to just concise the things. I know you might be aware of that. Let's have a revision, a quick revision of that, the areas where the particular nerve can be involved. Okay, the site and the nerve involved. So let's talk about the site and the nerve involved. At what all sites, what all nerve can be involved in any of the patient. That quick revision of the areas. Okay, so nerve entrapments, nerve injury at the particular site. So let's talk about that. Number one, starting from the upper limb and then to the lower limb. Number one, we can start from Guyon's canal. So what is a nerve that can be damaged, that can be compressed here in the Guyon's canal? The nerve that can be involved here is, we all know, it is the ulnar nerve. right? Guyon's canal between the pisiform and the hamate on the medial side, right? Number 1. Number 2, the site will be carpal tunnel syndrome. It will be carpal tunnel syndrome. Okay, let me just see. Ankur has just shared one issue. I'll just address it to the tech team. Okay. Anyone else facing the same problem? Okay, so carpal tunnel syndrome you all know is which nerve? Carpal tunnel syndrome we know is a median nerve, right? Carpal tunnel syndrome will be median nerve. So this side I am putting up all the sides, and this side I am putting the nerves which may be involved. Okay. Number 3, in the hand region, what is the site here? The site, the situation is known as chiralgia paresthetica. The situation is known as chiralgia paresthetica. What is that chiralgia paresthetica? Chiralgia paresthetica is compression of the superficial branch of the radial nerve, and that is what our question number 2 has been asking us. The superficial branch of the radial nerve, right? That is supplying this area, the sensation. That is chiralgia paresthetica. Okay. Number 4 is what you call the pronator syndrome. I hope everybody remembers it. What is that pronator syndrome? So pronator syndrome is compression of the median nerve under the pronator teres muscle. So median nerve under pronator teres in the forearm area. That is the compression of the median nerve. Number 5 is what we call as the cubital tunnel syndrome. Number 5 is what you call the cubital tunnel syndrome. That is a compression of which nerve? That is a compression of ulnar nerve. Where? At elbow. So compression of the compression of the ulnar nerve at the elbow. Then we have certain injuries around the elbow area. For example, you know, the radial head which is getting involved in what fracture? Very, very important entity here. The radial head which is getting involved in Monteggia fracture. Monteggia is what? The fracture of the proximal 1/3 of the medial bone, as well as dislocation of the proximal radioulnar joint. So proximal bone getting injured on medial side and proximal radioulnar joint getting dislocated is Monteggia. Which is the most commonest nerve involved? So this involves the posterior interosseous nerve. Right now it is posterior interosseous nerve. Number 7, the fracture of lateral condyle of humerus. We have discussed that already in the question number 1. The fracture of lateral condyle of humerus, if it goes into non-union, that involves which nerve? That will produce the late involvement of ulnar nerve. So tardy ulnar nerve palsy. So please remember the injury to the ulnar nerve on the medial side, cubital tunnel, the compression here, and the lateral fracture of the humeral area, it also can involve the ulnar nerve. So be very, very attentive while you are doing some questionnaire in your exams. Number 8, the fracture. When you talk about the fracture supracondylar humerus, when we talk about the fracture supracondylar humerus, which is the commonest nerve involved? You know, it is entry interosseous nerve, which is a branch of which nerve? Entry interosseous nerve, which is a branch of your median nerve, and that supplies which major 2 muscles? The flexor pollicis longus here, this one, and the flexor digitorum profundus, FDP. So how do we test it? The OK sign. Remember that? The OK sign. So AIN followed by median, followed by radial, followed by ulnar. This is in supracondylar sequence, the AIN. Okay. Number 9 is, you know, the fracture shaft of the humerus. So in fracture SOH is shaft of humerus. Shaft of humerus, it will be radial nerve, right? It will be radial nerve. Then you go a little above in the proximal humerus, we can say. When you say proximal humerus, this can be the dislocation as well as the fracture. So proximal humerus dislocation or the proximal humeral fractures, the dislocation of the shoulder or the fracture of the proximal humerus. It involves most commonly which nerve? The nerve most commonly involved is axillary nerve. The nerve most commonly involved is axillary nerve, proximal humerus. Okay. Number 11 is the clavicular area. You know, thoracic outlet syndrome. So thoracic outlet syndrome. What usually gets compressed here? The thoracic outlet syndrome. It is either the lower trunk of the brachial plexus or the subclavian vessels. Okay. So lower trunk of brachial plexus, which is made by your C8T1. The C8T1 roots. Either it can be lower trunk of brachial plexus, and here we can have compression of subclavian vessels as well. So you know that in the last year, they had asked you one image-based question about the subclavian vessel that was about the Roos test, like that. So that was about Roos test. It was your last year's question. Okay, then you talk about the lower limb. So in the lower limb, it can start with the inguinal ligament, and the situation over there is known as what? The myalgia parasthetica. The situation is known as myalgia. The situation is known as the myalgia parasthetica. Okay, what is that myalgia parasthetica? Myalgia parasthetica is compression of the lateral cutaneous nerve of thigh. Where usually this gets compressed? Lateral cutaneous nerve of thigh, around the or under the inguinal ligament, right? That will be under the inguinal ligament. We know it is a common site for injury to the lateral cutaneous nerve of thigh. And if this is getting involved, then what will be the problem to the patient? The sensory loss on the upper lateral aspect of thigh area. Okay, that is your myalgia parasthetica. Number 13, after myalgia, we can have a dislocation of the hip, that is posterior dislocation of the hip. The posterior dislocation of the hip. So it is, yeah, so posterior dislocation. We know that in the hip dislocation, posterior one is very, very important. So posterior dislocation of hip can produce compression of what structure? In the posterior dislocation of the hip, the compression will be of the sciatic nerve. And we know sciatic nerve compression is going to present to you with what kind of presentation? The sciatic nerve will have what? Foot drop. Will have foot drop. Okay, so posterior dislocation of hip, sciatic nerve, and the foot drop. Okay, and then we can have number 14. We say is the proximal fibula. When it is getting damaged, what nerve? It can involve the common peroneal nerve, which again causes the same problem of the foot drop. We go to number 15. In like the carpal tunnel, we have got a tarsal tunnel as well. Tarsal tunnel is a compression causing the structure, the tibial nerve, to get compressed. Okay, so tarsal tunnel is tibial nerves. And in the lower limb, the last one I'm putting here is number 16, that is known as a clinical entity which is known as Morton's metatarsalgia. Which is known as Morton's metatarsalgia. Now what exactly is that? Morton's metatarsalgia? It is a compression of digital nerves under the toes. It is compression of digital nerve under the metatarsal heads basically. So this is a situation which is seen in the diabetic people usually. Right, that is situation seen in diabetic people usually. And when the patient gets in the morning, when he puts his foot down on the ground, then what happens? There is sharp tingling sensation in the undersurface of the sole area, right? That will be putting the sharp shooting sensation in the toes area. Okay, so yeah, just give me 1 minute. I think now the class is going fine and everybody is able to just take it properly. Okay, so that is your, okay, so that is, these are the entrapment neuropathies that you must be aware of. Okay, that you all must be aware of. These are different entrapment neuropathies, so you should be aware of them, right? So this was our question number 1, and these are the areas. Okay, these are the areas where you must be very, very like sure that if a patient is getting some injury somewhere, then what can be the proper presentation. So as I said earlier, the presentations can be because of 2 reasons. Okay, presentations can be because of 2 reasons, or the failure of movement can be because of 2 reasons. Right? So this was our question. Yeah, so this can be because of 2 reasons, either the involvement of the muscles or the involvement of nerves. Right now what we have talked about is the involvement of the nerves. In a very, very soon while, I'll compile all the areas where the muscle will be involved, and that muscle, how that will be causing some restriction or abnormality in the movement of a shoulder area or the hip area, like that. So we'll compile that as well. So this is your compilation of involvement of the nerve. Okay, so this was your question number 2, so I've compiled it. That is a way to, I hope that I have been able to communicate the message to you that what exactly in the exams they're looking for. So they're looking for the presentation of the patient, why this patient is not able to perform this particular action, or why the patient is coming with this kind of attitude. That is a usual questionnaire which is expected from us. Okay, so we will see some more compilations in a while. Let's move on. Number 3, what do you suggest it as? A couple brings their 3-year-old son. So whatever is your answer, please put a question number and then answer it. Okay, so a couple brings their 3-year-old son to the emergency department reporting that he fell down from the bed. Okay, so again a question from trauma. So we have discussed question 1 trauma, question 2 trauma, number 3 is also trauma, and the child now is 3 years of age. He had a history of fall down, and when he fell down, he is keeping now the elbow in extended and forearm in pronated position. So elbow extended, forearm in pronated position like that. That is how he is keeping the hand. Okay, and is not allowing anybody else to touch. Otherwise, the child is playful. X-ray was done, but no fracture could be appreciated by the intern. No fracture has been appreciated by intern. What is the most likely diagnosis? What do you suggest, guys? What do you suggest? 3-year-old child keeping the elbow extended, forearm pronated. Is it seen in an elbow dislocation? Can be a possibility. Can be a possibility, but then the dislocation will be having some abnormal prominence and X-ray will be able to catch it very, very easily. Supracondylus, Montigias are the fractures which they will be pushing the child to keep the hand in a easy position. After fracture or after any sort of injury, you cannot keep the limb extended like that. Okay, that is one problem. Okay, so here, what do you think is the problem? The problem is, yes, absolutely correct. The gram-positive cocci, absolutely right. It is your nursemaid's elbow. What is the other name for nursemaid's elbow? It is what you call the pulled elbow. The nursemaid's elbow or the pulled elbow. The nursemaid's elbow or the pulled elbow. So nursemaids or pulled elbow. Yes, absolutely right. Nursemaid's elbow or the pulled elbow. What exactly is that situation? This is a situation where the radial head, let me show you the situations as well, the images as well from the trauma part. From the trauma part. So what exactly happens in pulled elbow is somewhat like this. A child gets pulled by the axial, force will be axial, something like that. See this. So elbow extended, forearm pronated. So what happens is this radial head actually comes out of the annular ligament. So this is what you call the pulled elbow or the nursemaid's elbow. Okay, so this is what you call the nursemaid's or pulled elbow. So what exactly is the definition of this? The definition for this is the radial head subluxation from annular ligament. Okay, the radial head subluxation from annular ligament. So please mind that it is not your elbow dislocation. Radial head subluxation from annular ligament. Okay, it will be annular ligament. Okay, now okay, so guys, one thing I wanted to convey to you that my team has floated one form, a Google form, which you are requested to fill up, so that we know that who all you are who are watching this video on the YouTube, which is running right now live, right? So if you can just fill up the form, give us your details, so they can provide you with the schedule, further schedule, that what all classes will be happening after my orthopedic class, what is the plan for this, and how this program has been made to target your upcoming NEET exam in the next 2023, which is most likely on the 5th of March. Okay, that has been, the date has been declared already. So please kindly fill up that Google form, and my team can just put that form again in the live chat, the YouTube channel that you're looking at right now. So kindly do fill that so that you can be sent the schedule, and team will be doing needful in the meanwhile. Okay, next one we say is a 26-year-old volleyball player, a 26-year-old volleyball player complains of severe pain around his ulnar side of the thumb. Okay, so severe pain, this is a thumb, the ulnar side of the thumb, they are telling you the pain, which is exaggerated after any match. One fine day after the match, he had severe pain and he applied ice, but the pain and swelling kept on increasing. X-ray was not significant. What can be the most likely diagnosis? What can be the most likely diagnosis? What do you think? What is the most likely diagnosis? Rupture of flexor pollicis. The flexor pollicis here. If the flexor pollicis is ruptured, thumb will be in extension only, and that will not be the pain only on ulnar side. That will be a diffuse pain all around the basically IP joint, maybe the attachment of the flexor pollicis. Okay, so that seems like a lesser possibility here. Skyer's thumb. What exactly is that? The Skyer's thumb, or what is the other name for that, is known as the gamekeeper's thumb. Okay, Skyer's thumb or the gamekeeper's thumb. What they are? Skyer's or gamekeeper's thumb, it is an injury to the ulnar collateral ligament of this thumb here, right? Ulnar collateral ligament of the thumb. So injury here, when somebody is trying to catch a ball or land on the ground or stuck against a pole, in whatsoever condition the thumb gets stretched like that, this area is having maximum stress, and the ulnar collateral ligament here getting damaged is what you call the this skiers or the gamekeeper's thumb. Okay, skiers or the gamekeeper's thumb. Right? What this volar plate injury will lead to? Do you recognize this? Volar plate, where is that volar plate? It is here, under the middle and the proximal phalanx base. So if that ligament is ruptured, what will happen? This joint, PIP, will sag down, and then there is a compensatory this deformity at the last joint. What do you call this? Volar plate injury or the volar plate destruction can lead to swan neck. And we know that, where do we see swan neck deformity? The swan neck is seen in our rheumatoid arthritis, right? Remember that. And decurving stenosynovitis, you already know, it is an inflammatory process here at the base, basically wrist area on the lateral aspect, right? That is an inflammation of the two tendons. So seems like a less possibility here. Okay, so that is on the lateral side, not on the medial side of the thumb. So this decurvance is on the lateral side. We will see all these questions, and you will realize that by the means of these 80 questions, 100 questions, whatever they have in the paper, we will be able to cover up whole orthopedics, right? All the trauma. So we are gradually covering up the bony traumas, the nerve involvement, and now we'll see some muscular attachments as well. So how all the questions can be framed for us in the exams. Okay, looking at this number 5 question, 5-year-old football player had a fall on the ground. X-ray shows he sustained a Bennett fracture at the base of the thumb. Okay, so X-ray is directly telling you which muscle provides the predominant deforming force. So first of all, we should know that what are the fractures which occur at the base of first metacarpal. We know there are 2 fractures. One they are mentioning here is Bennett's. And what is the other fracture that happens at the base of the first metacarpal? It is Rolando. What is the basic difference between the Bennett and Rolando? Bennett is like this, which has been given to you in the paper. This is the proximal part of the bone, and that's a distal bone. You can see the fracture line. And this distal part is having attachment of one of the muscle like that. What muscle is that? The abductor pollicis longus. It is APL. Right, that is abductor pollicis longus. So how to differentiate these 2 fractures? You know that Bennett, how we define Bennett? Bennett is defined as a partial intra-articular fracture. Bennett is defined as a partial intra-articular fracture. Rolando is defined as how? Rolando is defined as a comminuted intra-articular fracture. Rolando is comminuted intra-articular fracture. So Bennett is partial intra-articular, and Rolando is comminuted intra-articular. So this one is Bennett. And we know the deforming force of Bennett is APL. Now understand this. Whenever they are saying it's a deforming force, what does that mean? It will deform the bone. So if the force will deform the bone, so can we manage it conservatively? Absolutely no. So what we do? What is the treatment plan for this? So treatment plan will always be fixation. So it is a mandatory. Now as we said, fracture of necessity, this is also a fracture of necessity. Right? Why lateral condyle was a fracture of necessity? Because the common extensors are going to pull the fragment away. So we have to fix it all the time. And that is the same thing with Bennett as well, that APL has the tendency to displace it. Therefore, the treatment has to be what? Close reduction and internal fixation, which is done by what appliance? Close reduction, internal fixation is done by which appliance? The K wires. Right? The K wires. And Rolando or Bennett, what is a possible complication that they can do? We have to understand that logically. Not only in relation to these 2 fractures, but in relation to every other fracture as well. So this is the first metacarpal, and this one is your trapezium. So that can easily produce arthritis of this particular joint, the first joint. Okay, so complication that can be related to any intra-articular fracture is arthritis. It can be arthritis as well. Right? So these are very basic things that you need to understand. These are the same things for every intra-articular fracture which may be displaced like that. Okay, arthritis. Number 6. Okay, number 6 we said 17-year-old girl. So now we have a young girl, 17, who is presenting with complaint of pain in the knee area. Okay, who complains of pain in the knee area. She is complaining of pain. Pain increases on walking. Okay, and she got a radiological investigation done and was told that there is a cartilaginous defect in the lower femur. Fine. So what we are talking about? The cartilaginous defect in the lower femur. What is the situation she might be suffering from? So we are actually talking about what condition? We are talking about the osteochondritis. I hope you all can recall that. The osteochondritis. Osteo, the bone, the chondro, the cartilage, and itis, the inflammation. The inflammation of the bone and the cartilage is what you have called as the osteochondritis. Is what you have called as osteochondritis. Okay, so now osteochondritis, it is common at what position? So somebody has answered, like Abhinav answered as D, medial part of medial femoral condyle. Not exactly. D for which one? Gram positive. Kokai is answering D. For which one? I'm not sure for what you are answered. Okay, so understand the osteochondritis, what are the different osteochondritis we know? First of all, let's compile all the osteochondritis. The inflammatory process of the bone and the cartilage, the osteochondritis. So I'm putting all the osteochondritis together. So we need to understand two important things osteochondritis which are common at a particular age group. The smaller children's and all, these are usually common in children's. So we start again from the upper limb. So osteochondritis which may be common, they are, when you start from the upper limb, the scaphoid bone first, okay, what happened? Yeah. So starting from this, the scaphoid. Okay, scaphoid is what? The Preser's disease. Scaphoid is the Preser's disease. Okay. Number 2 we say is the osteochondritis of the lunate bone. What do you call that? The osteochondritis of lunate is known as the Kienbock's disease. So how they will look like? The bone will become shrunken or maybe fragmented. Okay, lunate. Number 3 is of the capitulum. What do you call that? Capitulum. It is known as the Panner's disease. Similarly, we have two invertebrae, but one which is more common, I am putting that here. I am putting that one here, the vertebra. What do you call that? Can you all recall that? It is Scheuermann's. One is Scheuermann, and what is the other one? One is Scheuermann's and other one is Kave's, but Scheuermann is more commonest one, right? Scheuermann's osteochondritis. Then number 5, we all have read that topic is very, very important. What is that? The osteochondritis at the head of femur. Osteochondritis at the head of femur. What do we call it that? That one, guys, in the osteochondritis of the head of femur, it is known as the Perthes disease, right? Remember that? The Perthes disease. Okay. Around the knee area, when you talk about, we usually have 3 kind of osteochondritis where the bone can easily get destroyed. Child will have severe pain. The 3 commonest areas of osteochondritis, we say one is lower femur. There is no special fancy name for this. This is simply known as osteochondritis of this area. So this one is common basically at the lateral margin of which femoral condyle? Your weight bearing condyle. The lateral margin of medial femoral condyle. The lateral margin of the medial femoral condyle. And why is it so common here? Because our weight bearing axis is passing that way. Okay, that is nearest to that area. So that is why. So when you talk about the lower femur, the weight from the upper femur to the middle femur to the lower femur and then to tibia, it passes through your medial femoral condyle. We know that medial condyle is under more stress. Now which part of medial condyle? The medial part or the lateral part? Obviously it is lateral part, right? So that is the reason why it is more common here. In the knee, the other common osteochondritis is at the lower pole of patella, right? It is at lower patella. What is that known as? At lower patella, this is known as SLJ syndrome. These are 3 friends, 3 people, Sinding, Larsen and Johnson, so SLJ syndrome. Okay, and one at the tibial tuberosity, which I believe is a very, very important one. The tibial tuberosity, what is that? Tibial tuberosity? Tibial tuberosity one is known as the Osgood-Schlatter disease. It is known as the Osgood-Schlatter disease. Okay, so Osgood-Schlatter disease. Number 7 is of the bone calcaneum. What do we call the osteochondritis of calcaneum? This is known as the Sever's disease. It is known as Sever's disease. Okay. Number 8 is of the bone navicular in the foot area, obviously. So it is known as Kohler's disease. It is known as Kohler's disease, right? Navicular. And number 9 is in the metatarsal areas. 2 commonest site is the second metatarsal's head, right? Second metatarsal's head. This osteochondritis is known as the Freiberg disease. It is known as the Freiberg disease. And the osteochondritis at the base of the 5th metatarsal, at the base of 5th metatarsal, is known as Island disease. It is known as the Island disease, right? So out of these, guys, if you ask me the most important one, as per my opinion, it has to be like your tibial tuberosity. Small bones with small fragmentation of the tibial tuberosity, lateral view of the knee will be given to you. Second commonest question they ask you from the osteochondritis, they have asked in past, not for last many years. It is now, which one of them is known as the tractional osteochondritis? So out of these many that we are mentioning here, out of these many, which one is a tractional osteochondritis? Which one is a tractional? Tractional means where there is a pull of a tendon of some muscle somewhere, right? So what are the tractional ones? Tractional one is calcaneum, because there is a attachment of what? Tendo Achilles, right? Then you have this one, the metatarsal fifth base, which is known as Island disease. So another tractional one, the peroneus brevis, tendo Achilles. Then you have this tibial tuberosity and lower pole of patella, the ligamentum patelli. So these are 4 tractional osteochondritis. These are 4 tractional osteochondritis. Okay, these are 4 tractional osteo. Very good. Yes, yes, absolutely right. So my team has shared one form, guys. If you want to know about the further schedule of the program, please do fill that form if you are on the YouTube channel right now. Okay, so please do fill that form so that details can be shared to you over your the numbers details that you provide to the team. So they'll be sharing the details with you, which is the next class and which will be live one. Okay, so these are different osteochondritis. I think we are compiling. Please do let me know those who are there with me. Kavinesh, China, returns, gram positive cocci, the doctor, Rakshita, Priya, and all of you who are here right now with me. So are we going at a good pace? Are you able to make the notes down? And I think we are going to compile all the things like that only in the tabulated form. The whole ortho part we are just going to compile. So one section will be there from every part, trauma, tumors and all like that. So we are going to compile it. Are we going at a good pace? Everyone do kindly respond here on the group so that I can see. Okay, so yeah. So coming on to the next one. Yeah, Kavinesh. Thank you, Kavinesh, for the response. So now moving on to the spine, this question. So let me show you the image from the spine so that you, okay, so in the spine, what is important? The next question is all about the spine only. Okay, next question is about the spine only. So a 25-year-old volleyball player presents to the OPD. So we have a young fellow right now. And who is a volleyball player, presents to the OPD with complaints of low backache, pain with a radiculopathy to the right leg for last 4 months. So kind of not a very acute case. It's a chronic kind of old case now, 4 months old, who is having radiculopathy through the right leg. His blood tests are okay. X-ray AP view and oblique view shows no abnormality. Lateral view shows slight translation of L5 on the sacrum. Okay, so view given to us is a lateral view. And there is slight translation of the L5 bone on the sacrum. Which is the most likely diagnosis? What do you suggest when there is a translation of sacrum? You know, what is the meaning of these 4 options we have? See, spondylolysis, what exactly is that? Lysis is a break or a breach, you can say, at what area of the bone? Breach at pars interarticularis. So I do believe you already have the idea about the structures of the vertebra. Where is the pars located? Let me just show you very quickly. If you are like, if you forget these things, or if you have forgot that where exactly is the pars area. So let me just put that image for you. So when you look at these, you know, structure of the vertebra, have a look. This area, this is an oblique view of the spine, right? This is an oblique view. So here you all can see this dog that is being made here. This one. The dog that is being made here along my pointer. You can see all this pointer. Just over my head you can see the pointer. So when you see the oblique view, this is a dog being created. And this superior articular facet and the inferior articular facet, the area in between, this neck area of the dog is made by what? The pars interarticularis. Okay. So break at this area is pars interarticularis, is spondylolysis. What is the best view to see spondylolysis? We know the best view to see spondylolysis, it is your oblique view, right? That would be the oblique view. And listhesis, when you say it is listhesis, what does that mean? Listhesis means that the bone is slipping over the another bone. So that listhesis is slip of a bone over another bone. What is spondylitis? Obviously this is itis, so inflammatory change. And what is that spondylosis? Spondylosis means a degenerative change. Okay, like the osteophytes, decrease in the joint space. So spondylosis can be simply called as the osteoarthritis of the, just like you have the osteoarthritis of knee. So this is osteoarthritis of the spine. So spondylosis is a degenerative change. So here the diagnosis will be spondylolisthesis. Now for lysis you need an oblique view, and for listhesis obviously you need what view? You need, the best view would be the lateral view. The best view would be the obviously lateral view. Okay. So now when you have the lateral view over there, in some advanced cases, like if you look at this particular image, this X-ray, all of you can very well appreciate that this one is the sacrum here, and this is the L5 vertebral body. So we can very well appreciate the slip. And now see the upper margin of the sacrum and the L5, they are at the same level. Now if we take a AP view, what are we expecting here? In the AP view, if you observe, you can see that there is a hat like that. Can you see this? And what do we call this sign? The inverted Napoleon hat sign. Okay, so lateral view can very well show you the slip of one vertebra over the another vertebra, and this is going to show you what? In advanced cases, we must write down in advance in AP view. That is not in the initial cases only, it is only when the bone has slipped to that category. Okay, so what is that now? In AP view, advanced cases, in AP view, advanced cases, it is known as what? Advanced cases, this is the inverted Napoleon hat sign. So that is known as inverted Napoleon hat sign. Okay, so please do remember inverted Napoleon hat sign. And what did we call this? The spondylolysis, the break in the pars area. What do we call this? That is given a fancy name as the Scotty dog appearance. Yes, somebody mentioned it very, very right. Okay, Scotty dog appearance. Okay, it will be Scotty dog appearance, right? So it's C for 7. No, absolutely no. I've given you the reason, I believe. Okay, so this is listhesis. So please mark and remember the important areas. Scotty dog, oblique view, advanced cases, inverted Napoleon sign. Best way is always the lateral view. This is our listhesis. Okay, this is our listhesis. I hope this point is clear to everybody. So lysis and listhesis. So lysis will be seen as a B-headed dog appearance, the Scotty dog appearance or the Scotty dog sign, right? So this is Scotty dog appearance is a normal thing, and break in the neck of the dog is a pathology. So when there is a breach, it will be known as, instead of the Scotty dog appearance, it will be known as what? Scotty dog sign or the B-headed Scottish dog, like that. Different names have been used. Okay, that is about the spinal area. Then we have, okay, so then we have the next question, the 30-year-old woman. So now we have a 30-year-old woman who comes to the physician 6 hours after falling on her outstretched right hand. That means it's an acute case. So a young woman, acute case of trauma coming to you, and she has pain and limitation of the movement in her wrist. Okay, but denies loss of sensation, tingling and numbness. The right wrist is mildly swollen and its range of passive motion is limited compared with the left side. Perfect. So pain is there basically right now, restriction of movement is there. Palpation elicit maximum tenderness between the tendons of extensor pollicis longus, EPL and the abductor pollicis muscle. Okay, distal pulse is okay. Plain X-ray is done in AP lateral oblique views, but it doesn't show you any fracture. At this time, which of the following is the most appropriate next step? What do you suggest? Please suggest me some answer for this. Question number 8. 8, you are saying that Abhinav from YouTube is saying that you should go for MRI. Okay, Abhinav says with going for MRI. Why? What is the diagnosis we are expecting here? So patient here in question number 8 is most likely a case of what? The pain between the tendon of extensor pollicis and abductor pollicis. Most likely in the snuff box they are saying pain. And the anatomical snuff box tenderness is signifying what trauma? We know that it's a fracture of scaphoid, right? And what is so special about the scaphoid we already know? It's an acute case. Okay, it's an acute case. So plaster application, Priya is saying, Shubhajit is saying that it is a plaster application. So I do go with the students who are saying that it's a plaster application. Reason being, let's understand the fracture. We said most likely clinically they are trying to tell you about the fracture scaphoid. Agreed. Why so? Why so? Because see, in the fracture of the scaphoid, we already know that for up to 2 weeks, the normal X-rays might not be able to show you the fractures for up to how long? For up to 2 weeks at least. Okay, so fracture scaphoid might not be able to show you the injuries for up to 2 weeks. Okay, that is what they are saying. AP lateral oblique clean. But clinically, I know that tenderness is there in the snuff box, which is very specific for the scaphoid only. So scaphoid we know is a bone which has got, you know, maximum chances of injuries in the wrist area of all the carpals. And for the scaphoid, you should know all the points, you should remember all the points, that it is the most common carpal to get fractured, right? It is the most common carpal to get fractured. When you are talking about the fractured, you know, you should know about the most commonest, everything now, most commonest site of injury. It is the softest area, that is the waist area of the scaphoid. If the waist is getting involved in fracture, what is the most commonest site for avascular necrosis? Because we know the scaphoid has got what? Retrograde kind of blood supply, isn't it? The scaphoid has got the retrograde kind of blood supply, and therefore the area to get involved into the avascular necrosis, it is proximal pole. It is proximal pole. So most common carpal to get fractured, site, waist and the avian, proximal pole. Okay. Tenderness, classically yes, the tenderness will be seen where? The tenderness after the injury, the classical site for the scaphoid, it is anatomical snuff box. It is anatomical snuff box. Okay, and X-ray we know, X-ray will take time to show you the injuries. X-ray may not show you injuries for up to 2 weeks. X-ray, yeah. So X-ray may not show fracture for how long? Fracture for up to 2 weeks. Being a soft area injury, it might not be visible on the X-rays for up to 2 weeks. Okay, so in that case, what you do? In that case, you don't go for MRI because you are suspecting all the time avian. Avian is not seen instantly within 6 hours. No, it takes some time. Okay, so initially, what is my aim? Is my aim to find the injury or is my aim to treat the patient? So we always remember that in orthopedics, we are not running after the investigations. We want to relieve the patient. We want to treat the patient. Okay, so X-rays, if they are not showing any injury, the next step will always be the treatment. And what is the treatment plan? To give the plaster in a glass holding or the tumbler holding position like that. Okay, glass holding or tumbler holding position like that. Okay, so treatment has to be given conservative in a plaster has to be given in a glass holding or a tumbler holding position. So plaster is given. What is the most common complication we know related to the scaphoid? The most common complication is always non-union, followed by other complication which is avascular necrosis. And yes, you are right here that for this non-union or for this avian, what is our preferred investigation modality? It has to be all the time MRI. It has to be preferred all the time MRI. So non-union, avian and MRI. Okay, so this is, you should know about these basic parameters. So yeah, so I hope sir also trapezium. Yeah, scaphoid and trapezium are the usual ones to get fractured. Yes, you are right. Rest of the 6 carpals are injured in hardly like 5%, 4% of cases. 90-95% of the wrist bone injuries are constituted by scaphoid and triquetrum. This trapezium, okay, the basically triquetrum, not the trapezium. Dr. Sneha. So it is the scaphoid and triquetral carrying most of the injuries of the carpal bone. Trapezium, trapezoid or all other bones are in less than 5%. Okay, so this is about the number 8. So here the best answer would be to go for the plaster application rather than trying to waste time or money or patients just resources for a MRI. Aim is going to be same. Even after the MRI confirms it's an injury, the plan is going to be same. So we go with the plaster application. Okay. Right, so patient had the injury as shown here, and after which he started having off and on episodes of cold and clumsiness feeling in the hand. What is the most likely structure that can compress under clavicle? We have already talked about it. The clavicular area, the thoracic outlet syndrome usually causes compression of what? Either the lower trunk of the brachial plexus, so it cannot be upper trunk here, or it can cause a compression of the subclavian vessels. Okay, how do we clinical assessment? How to do clinical assessment of subclavian vessel compression? So clinical assessment of the subclavian vessel compression is done by what test? You know about those tests. One is a Roos test. And other is a Adson's test. So Roos test or the Adson's test. So how to do that? The rules will be, ask the patient to keep abducted and extended these shoulders, keep on closing and opening the fingers. So if there is a subclavian compression, these pulses will become feeble. And if it is an Adson test, what do we do here? We keep on feeling the pulse. We ask the patient to extend the neck and rotate to the side on which we are checking it. So that is again going to compress the pulsations, make the pulses feeble. So Roos and Adson. Okay, the Roos and Adson. These are the two tests for number 9. Okay, so that is the answer for here. Number next, 54-year-old female, marathon runner. So now we have an elderly person, marathon runner, presents with pain in her right wrist that resulted when she fell. So again a question from trauma. Okay, and on her outstretched hand. Radiographic studies indicate an anterior dislocation of a carpal bone. Which of the following bone is most likely dislocated? What do you suggest? 9th B, you are saying lunate. Absolutely correct, because this, you can see this whole radius and the rest of the carpals are still in the line. and who is standing out of its bed, it is this area, which is known as the lunate. So lunate dislocation. How the lunate dislocation is little different from the perilunate dislocation? It is little different from perilunate dislocation by the reason that I'll show you both these images together so that we can understand it. Okay, have a look. The normal X-ray first. So normal X-ray, distal radius here, the lunate here, and if it is a lunate dislocation, rest of the carpals are still in line, but lunate is standing out here. The lunate is standing out here. And on the other hand, with the other entity which is known as perilunate dislocation. What is that? All the carpals now they go dorsally and they are trying to push the lunate on the volar side, palmarly. So this has been your All India question some 3 years back in 18, I believe, that perilunate dislocation is defined as. So lunate has got 4 important questions. I must tell you that. One, about the lunate, that lunate is the most commonest carpal to dislocate. That we have already mentioned. So lunate is the most common carpal for dislocation. We should know what all points about the lunate. Lunate dislocation. Whenever the lunate will dislocate, what is the special sign we know? What is the special sign we know? So whenever the lunate will dislocate, it is known as what you call the spilled teacup sign. See this? The lunate coming out of it and the lunate like this. This is known as spilled teacup or the teapot sign. So spilled teacup sign. That is another point. So spilled teacup sign. Another thing is when the scaphoid and lunate, they are getting, away from each other. What you call as the scapholunate dissociation. What you call as the scapholunate dissociation, somewhat like that. See the scaphoid and lunate and see the dislocated ones. Okay, so this is scaphoid and lunate going away from each other, and this is the gap between the scaphoid and lunate, right? This is what you call, what is the sign? The special sign after this? No, this is what you call the Terry-Thomas sign. So please note it down. The scapholunate dissociation, the scapholunate going away from each other, it is known as what? The Terry-Thomas sign. Okay, Terry-Thomas sign. So 3 things I told you. One, about dislocation, spilled teacup sign. Second, I told you is the scapholunate dislocation, Terry-Thomas sign. And third, I told you is perilunate dislocation. You want to see that again? We can have it again, not a problem. What I'll do, I'll put this picture in your group. I'll just have a click of this and I'll put that in your group so that you can just revise it whenever you want. I'll just put that in your group as well. So this is the normal picture and so this is there in your group now. I posted that picture. So Priya asked for it, so I put that in your group as well, so that whenever you want to revise, you can use it. Okay, so these are 4 points about the 3 points. We said 3 points, and the 4th point I told you about the lunate was what? The osteochondritis. What did you call the osteochondritis of lunate? The Kienbock's disease. When the lunate will become very, very small, very, very shrunken, and that will be causing pain here, the osteochondritis. So 4 important points about the lunate. Okay, so guys, now we will be stopping the YouTube live relay. So this class, those who are watching me on YouTube, I must tell you that my team has floated one Google form. If you wish to be a part of this program, you can very well fill that Google form and our team will be connecting with you. Our team will be sharing the further schedule of this Fast Track T&D. Okay, and you can very well be a part of it if you want to join this program, and you can very well connect with our team as well, right? So again, I'm Dr. Sushil, and if you want to have any other kind of discussions, academic issues, you are very much welcome to just connect with me. I'm very much there on the Telegram group. Okay, so I wish all the students a very best of luck for the exams. Those who are watching me on the YouTube channel, so we are now stopping this relay. All those students who are already with us on the DBMCI, this group, the Telegram group, who are connecting with me, so just hold on for a while. We are just changing the link, and in a couple of minutes you will be getting the link again. So we are going to continue right now. There's not a break, just a change of the link. So stay there. I'm connecting with you all. So thank you so much everyone on the YouTube channel. So just connect with us through the Google form. Thank you.